Today I'll be talking about SAVAYSA, also known as edoxaban. It is a factor Xa inhibitor. It is white to pale yellowish white crystalline powder. SAVAYSA is available for oral administration as a 60 mg, 30 mg, or 15 mg round-shaped film-coated tablets. So let me go over vascular injury, the concept of vascular injury, before we move on and discuss the medication a bit more. So following vascular injury, the body undergoes hemostasis, arrest of a bleed, and that's really essential to life. Within our vascular system, the blood remains in a fluid state, and that produces a steady state of blood volume, pressure, and flow. And the idea behind that is to really transport oxygen, nutrients, plasma proteins, and waste. So if there is a vascular injury, like any damage or if there is a bleed, this involves a series of reactions involving a complex interplay of thrombogenic and antithrombotic stimuli. So you'll basically see a complex sequence of events, and those include formation of a platelet plug, activation of the coagulation cascade, formation of a blood clot dissolution, and fibrinolysis. So since there is this disruption that has occurred to this delicate system of checks and balances, that may lead to inappropriate clot formation within the blood vessel, and that therefore obstructs blood flow or embolizes to a distant vascular bed. So in the late 1800s, Dr. Rudolf Virchow, who's a German pathologist, he recognized the role played by blood vessels, and he recognized the three main factors that lead to pathologic clot formation. And those include endothelial injury. So for example, that can occur as a result of atherosclerosis, which leads to platelet adhesion and aggregation. Abnormalities of blood flow. So if there is turbulent blood flow in the arteries and there is stasis, for example, of blood flow in the veins, that will promote thrombus formation. And finally, hypercoagulable states. And those three made up the Virchow's triad in regards to Dr. Rudolph's discovery. Normally, endothelial cells in blood vessels maintain the blood flow by producing a number of substances that inhibit platelet adherence, activation of the clotting cascade, and it facilitates fibrinolysis, like I mentioned. Vascular injury, though, results in exposure of the subendothelium. So the exposed subendothelium activates platelets. So the platelets are activated, and then they release substances that expose glycoprotein 2b3a receptor complex into the circulation, and that causes platelets to adhere to one another. At the same time, the damaged vascular tissue releases tissue thromboplastin, or also known as tissue factor, and that activates the extrinsic pathway of the clotting cascade. When looking at the coagulation cascade or the clotting cascade, it is initiated through the intrinsic pathway as well as the extrinsic pathway. When looking at the intrinsic pathway, it's activated when Hageman factor, factor 12, in the plasma contacts with subendothelial substances exposed by vascular injury. And the extrinsic pathway, it's generally activated when tissue thromboplastin or tissue factor, a substance released by damaged endothelial cells, makes contact with one of the clotting factors. And that clotting factor happens to be clotting factor number 7. Which is also known as serum prothrombin conversion factor. Both lead to a final common pathway when each has activated factor 10, and this directly proceeds to clot formation. So let's look at it in a bit more detail. When you're looking at the intrinsic pathway, after the activation of factor 12, this leads to the activation of factor 7, which acts upon factor 11 and causes its activation to 11A, which acts upon factor 9 and forms factor 9A. And these reactions, as you can see, these conversions, they require calcium ions. Then the activated factor 9, which is 9A, in the presence of factor 8A and calcium ions. By the way, 8A is derived from factor 8, and combined with the calcium ions causes the activation of factor 10. And then really events are similar to the extrinsic pathway. So let's look at the extrinsic pathway. The extrinsic pathway, as mentioned earlier, the damaged endothelial cells, they release tissue factor, which is also known as tissue thromboplastin. And that leads to the activation of factor 7 to factor 7A. And tissue factor combines with the activated factor 7 in the presence of calcium ions and causes the conversion of factor 10 to 10A. Activated factor 10 in the presence of calcium ions and in the presence of factor 5 forms the prothrombin activator, which leads to the conversion of prothrombin to thrombin. Really, both the intrinsic and the extrinsic pathways lead to prothrombin activator, which is factor 10. Once it is activated, again, how is it activated? It's activated in the presence of calcium ions and factor 5. And that converts prothrombin into thrombin, which leads to the conversion of fibrinogen to fibrin. And in the presence of factor 13, which is your fibrin stabilizing factor, and calcium ions, it converts them into a stabilized fibrin clot. For the mechanism of action, edoxaban is a selective inhibitor of factor 10A. It does not require antithrombin 3 for antithrombotic activity. It does inhibit free factor 10A and prothrombinase activity and inhibits thrombin-induced platelet aggregation. Inhibition of factor 10A in the coagulation cascade reduces thrombin generation and reduces thrombus formation. It is indicated to reduce the risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation. There is a key limitation of use for non-valvular atrial fibrillation, and that is that it should not be used, edoxaban should not be used in patients with creatinine clearance above 95 ml a minute because of an increased risk of ischemic stroke compared to warfarin. It is also indicated for the treatment of deep vein thrombosis and pulmonary embolism following 5 to 10 days of initial therapy with a parenteral anticoagulant. For dosage and administration, for non-valvular atrial fibrillation, the recommended dose of SAVAYSA is 60 milligrams, taken orally once a day. You have to assess the creatinine clearance as calculated using the Cockcroft and Gault equation before initiation of therapy with SAVAYSA, because it was made clear earlier that you cannot use SAVAYSA in patients with a creatinine clearance that is above 95 ml a minute. You want to reduce the SAVAYSA dose to 30 mg once daily in patients with creatinine clearance 15 to 50 ml a minute. For the treatment of deep vein thrombosis and pulmonary embolism, the recommended dose of SAVAYSA is 60 mg, taken orally once daily following 5 to 10 days of initial therapy with a parenteral anticoagulant. The recommended dose of SAVAYSA is 30 mg once daily in patients with a creatinine clearance of 15 to 50 ml a minute, patients who weigh less than or equal to 60 kilograms, or patients who are taking certain concomitant PGP inhibitor medications. This is all based on clinical study data for this particular indication. PGP inhibitors include ketoconazole, quinidine, verapamil, erythromycin, cyclosporin, or amiodarone. In terms of transitioning to or from SAVAYSA and warfarin, we're going to start with warfarin to SAVAYSA. So to transition from warfarin or other vitamin K antagonists to SAVAYSA, you simply discontinue the warfarin and start the SAVAYSA when the INR is less than or equal to 2.5. To transition from SAVAYSA to warfarin, they give you two options, the oral option and the parenteral option. For the oral option, for patients taking 60 milligrams of SAVAYSA, you want to reduce the dose to 30 milligrams and begin warfarin concomitantly. For patients receiving 30 milligrams of SAVAYSA, you want to reduce that dose to 15 milligrams and begin warfarin concomitantly. INR must be measured at least weekly and just prior to the daily dose of SAVAYSA to minimize the influence of SAVAYSA on INR measurements. Once a stable INR of greater than or equal to 2 is achieved, SAVAYSA should be discontinued and the warfarin continued. For the parenteral option, you want to discontinue the SAVAYSA and administer a parenteral anticoagulant and warfarin at the time of the next scheduled SAVAYSA dose. Once a stable INR of greater than or equal to 2 is achieved, the parenteral anticoagulant should be discontinued and the warfarin continued. For patients who are unable to swallow whole tablets, SAVAYSA tablets may be crushed and mixed with 2 to 3 ounces of water and immediately administered by mouth or through a gastric tube. The crushed tablets may also be mixed into applesauce and immediately administered orally. SAVAYSA is contraindicated in patients with active pathological bleeding. So for warnings and precautions, the first warning here that I will mention is the reduced efficacy in non-valvular atrial fibrillation patients with creatinine clearance above 95 ml a minute. SAVAYSA should not be used in patients with creatinine clearance above 95 ml a minute. In the randomized ENGAGE trial, the non-valvular atrial fibrillation patients with creatinine clearance above 95 ml a minute had an increased rate of ischemic stroke with SAVAYSA 60 milligrams daily compared to patients treated with warfarin. So in these patients, another anticoagulant should be used. The second warning here is the increased risk of stroke with discontinuation of SAVAYSA in patients with non-valvular atrial fibrillation. Premature discontinuation of any oral anticoagulant in the absence of adequate coverage or adequate alternative anticoagulation does increase the risk of ischemic events. So if you were to discontinue SAVAYSA for a reason other than pathological bleeding or completion of a course of therapy, you do have to consider coverage with another anticoagulant. The third warning here is the risk of bleeding. SAVAYSA does increase the risk of bleeding and can cause serious and potentially fatal bleeding. You want to promptly evaluate any signs or symptoms of blood loss. Also, you want to discontinue SAVAYSA in patients with active pathological bleeding. But do remember that concomitant use of drugs affecting hemostasis may increase the risk of bleeding. Such drugs include aspirin and other antiplatelet agents, other antithrombotic agents, fibrinolytic therapy, chronic use of NSAIDs, selective serotonin reuptake inhibitors, and serotonin norepinephrine reuptake inhibitors. The most serious adverse reactions reported with SAVAYSA were related to bleeding. For example, in the ENGAGE study, bleeding was the most common reason for treatment discontinuation. In terms of non-bleeding adverse reactions, the most common non-bleeding adverse reactions for SAVAYSA 60 milligrams versus warfarin were rash and abnormal liver function tests. Interstitial lung disease was reported as a serious adverse event on treatment for SAVAYSA 60 milligrams and warfarin. Many of the cases in both treatment groups were confounded by the use of amiodarone, which also has been associated with interstitial lung disease, or by infectious pneumonia. Co-administration of anticoagulants, antiplatelet drugs, and thrombolytics may increase the risk of bleeding. You want to evaluate any signs or symptoms of blood loss if patients are treated concomitantly with anticoagulants, aspirin, other platelet aggregation inhibitors, and/or NSAIDs. It is important to note that long-term concomitant treatment with SAVAYSA and other anticoagulants is not recommended because it does increase the risk of bleeding. Short-term co-administration may be necessary for patients transitioning to or from SAVAYSA. For PGP inducers, you want to avoid the concomitant use of SAVAYSA with rifampin. For PGP inhibitors, what they found was that based on clinical experience from the ENGAGE trial, dose reduction in patients concomitantly receiving PGP inhibitors resulted in edoxaban blood levels that were much lower than in patients who were given the full dose. So there shouldn't be a dose reduction in patients who are taking SAVAYSA plus a PGP inhibitor. Moving on to the use of SAVAYSA in special populations. In terms of renal impairment, renal clearance accounts for approximately 50% of the total clearance of edoxaban. So therefore, edoxaban blood levels are increased in patients with poor renal function compared to those with higher renal function. So in that case, you want to reduce the SAVAYSA dose to 30 milligrams once daily in patients with creatinine clearance 15 to 50 ml a minute. There are limited clinical data with SAVAYSA in patients with creatinine clearance less than 15 ml a minute. So SAVAYSA is therefore not recommended in these patients. Hemodialysis does not significantly contribute to SAVAYSA clearance. Do keep in mind though, as renal function improves and edoxaban blood levels decrease, the risk for ischemic stroke increases in patients with non-valvular atrial fibrillation. In terms of hepatic impairment, the use of SAVAYSA in patients with moderate or severe hepatic impairment is not recommended, as these patients may have intrinsic coagulation abnormalities. There is no dose reduction requirement in patients with mild hepatic impairment. Based on clinical experience from the Hokusai VTE study, you want to reduce the SAVAYSA dose to 30 milligrams in patients with body weight that is less than or equal to 60 kilograms. For a brief overview of pharmacodynamics, as a result of factor Xa inhibition, edoxaban prolongs clotting time tests such as prothrombin time and activated partial thromboplastin time. Changes were observed in PT, INAR, and APTT at the expected therapeutic doses. However, those changes were minute, they were small, subject to a high degree of variability, so therefore they are not useful in monitoring the anticoagulant effect of edoxaban. Following oral administration, peak pharmacodynamic effects are observed within 1 to 2 hours, which does correspond with peak edoxaban concentrations, or the Cmax. Edoxaban does display an approximately dose-proportional pharmacokinetic profile. For absorption, following oral administration, peak plasma edoxaban concentrations are observed within 1 to 2 hours. The absolute bioavailability of edoxaban is about 62%. Food does not affect the total systemic exposure to edoxaban. And SAVAYSA was administered with or without food in the ENGAGE trial, as well as the Hokusai VTE trials. Edoxaban is eliminated primarily as unchanged drug in the urine. The renal clearance accounts for approximately 50% of the total clearance of edoxaban. Metabolism and biliary or intestinal excretion accounts for the remaining clearance. The terminal elimination half-life of edoxaban following oral administration is 10 to 14 hours. In a dedicated pharmacokinetic study, the total systemic exposure to edoxaban for subjects with creatinine clearance of 50 to 80 ml a minute was increased by 32%, and it was increased by 74% for patients with a creatinine clearance that is 30 to 50 ml a minute. It was increased by 72% for patients with creatinine clearance of less than 30 ml a minute, and it was increased by 93% for patients who are undergoing peritoneal dialysis. And this is all relative to subjects with a creatinine clearance that is greater than 80 ml a minute. In terms of hemodialysis, a 4-hour hemodialysis session reduced the total edoxaban exposure by less than 7%. And that is why hemodialysis does not significantly contribute to edoxaban clearance. For weight, in a population pharmacokinetic analysis, the total exposure in patients with median low body weight, which is 55 kilograms, was increased by 13% as compared with patients with median high body weight, which was 84 kilograms. Finally, for the reversal of anticoagulant effect, there is no established way to reverse the anticoagulant effects of edoxaban, which can be expected to persist for approximately 24 hours after the last dose. A specific reversal agent for edoxaban is not available. Hemodialysis does not significantly contribute to edoxaban clearance. Agents such as protamine sulfate, vitamin K, and tranexamic acid are not expected to reverse the anticoagulant activity of edoxaban. The use of prothrombin complex concentrates or other procoagulant reversal agents, such as activated prothrombin complex concentrate or recombinant factor 7A, may be considered, but it has not been evaluated in clinical outcome studies. When prothrombin complex concentrates are used, monitoring for anticoagulation effect of edoxaban using clotting tests such as the PT, INR, or APTT, or anti-10A activity is really not useful and is not recommended. Thanks for watching, and I hope you like, comment, and subscribe.